Hi, my name is Claire Dewald, and I'm in Professor Swenson's Biology 2114 lab class at Augusta Tech. We were asked to discuss the following processes of ventilation with regard to the muscles or the other tissues involved in the movement of gases in response to differences in intrapulmonary pressure and atmospheric pressure. And there are two processes involved in ventilation, and that's inspiration and expiration. So before I begin explaining these two processes involved in pulmonary ventilation, I'm going to discuss the pressures that are vital to overall respiration. All respiratory pressures are always described as relative to atmospheric pressure, which is the pressure exerted by the air or gases surrounding the body. At sea level, atmospheric pressure is 760 millimeters of mercury, or 1 atm, 1 atmosphere. First, there is intrapulmonary pressure, which is the pressure in the alveoli. The intrapulmonary pressure rises and falls with the phases of breathing, but it always equalizes with the atmospheric pressure. Next, there is intrapleural pressure. Intrapleural pressure is the pressure within the pleural cavity. It rises and falls with the phases of breathing as well, but it is always around 4 millimeters of mercury less than the intrapulmonary pressure. And intrapleural pressure is always negative relative to intrapulmonary pressure. The transpulmonary pressure is the difference between the intrapulmonary pressure and the intrapleural pressure. This is the pressure that keeps the lungs from collapsing. The size of the transpulmonary pressure determines the size of the lungs at any given time. It is critical to have a negative intrapleural pressure. Now I will discuss the two processes involved in pulmonary ventilation, which, like I said earlier, is inspiration and expiration. It is also important to note that gases always flow down their pressure gradients. During normal, quiet, or resting inspiration, the inspiratory muscles are activated. The inspiratory muscles are the diaphragm and the external intercostal muscles. The diaphragm is the most important of these two. When the diaphragm contracts, it moves inferiorly and flattens out. This causes the superior-inferior height of the thoracic cavity to increase. When the external intercostal muscles contract, they lift the rib cage, pulling the sternum superiorly. The ribs are raised and swing outward, causing the diameter of the thorax to expand. The actions of the inspiratory muscles are enough to increase the thoracic volume by 500 milliliters. And 500 milliliters is the usual volume of air that enters the lungs during quiet inspiration. When the dimensions of the thoracic cavity are increased, the lungs are stretched, causing the intrapulmonary volume to increase. This leads to intrapulmonary pressure decreasing by about 1 millimeter of mercury, which causes air to rush into the lungs along the pressure gradient. Inspiration is complete when the intrapulmonary pressure equalizes the atmospheric pressure. It is important to note that while all of this is taking place, that the intrapleural pressure drops to about -6 millimeters of mercury relative to atmospheric pressure. During deep or forced inspiration, which occurs during strenuous exercise or in pulmonary diseases, accessory muscles help increase thoracic volume. The scalenes and sternocleidomastoid of the neck and the pectoralis minor of the chest raise the ribs even further. Also, the erector spinae muscles extend the back. The second process of ventilation is expiration. Quiet expiration is a passive process that relies on the elasticity of the lungs rather than muscle contraction. When the inspiratory muscles relax, the rib cage is lowered and the lungs recoil. This causes the thoracic and the intrapulmonary volumes to decrease, which compresses the alveoli. Intrapulmonary pressure rises to about 1 millimeter of mercury above atmospheric pressure. When intrapulmonary pressure is greater than the atmospheric pressure, the pressure gradient forces gases to flow out of the lungs. In contrast to quiet expiration, forced expiration is an active process, and it is dependent upon abdominal wall muscles, specifically the oblique and the transversus muscles. When these muscles contract, the intra-abdominal pressure is increased, forcing the abdominal organ superiorly and against the diaphragm. Also, the contraction of the abdominal wall muscles lowers or depresses the rib cage. The other muscles involved in forced expiration are the internal intercostal muscles, and they help to depress the rib cage as well as decrease the thoracic volume. Well, that is it, and thank you for watching my video.